LSU HCSD routinely disseminates information through an application we call our drilling platform system. The drilling platform will use data from our individual partners' data warehouses. Each of your sites or hospitals will only have access to your data. You will be able to see aggregate data, which is combined for all of the individual partners. This will allow your site or hospital to compare your measurement results to the aggregate value for all sites. Now, for an overview of the drilling platform system, there are 4 platforms to choose from: the program-related platform, PQRS, HEDIS, and directional drilling platforms. We will illustrate the use of the drilling platform application with our program-related platform. The program-related platform provides a way to examine measurement results at your site level, and within your site at your clinic levels, and within your clinics, your clinician levels. This platform is organized around chronic disease and population health areas such as asthma, cancer, diabetes, heart failure, HIV, and medical home. Each topic has its own set of measures. If you click on the indicator drop-down box for diabetes, you will see there are 45 available diabetes-related measures. Highlighting any particular measure brings up a more detailed definition of the measure, such as the fraction of diabetes patients whose most recent blood pressure reading was below 140/90. You will see the long definition in the box below. Every indicator has a default denominator, or patient subgroup. The most basic summary is a graph of the site's value for the measure over time compared to the aggregate value for all sites. In this case, the request generates a graph showing the value of the measure by quarter over the past 4.5 years. The first line of the title states the disease area and the indicator selected. The second line specifies the denominator. By default, this measure is summarized for the medical home sustained clinic group, meaning patients who had medical home visits within the past 6 months and a history of clinic visits extending back at least 12 months. Along the x-axis at the bottom of the graph is the timeline by quarter from January 2009 through June 2013. Along the y-axis on the left side of the graph is the relative scale of the indicator values. These numbers will change depending on the resulting values. The site's values over time are shown by the solid line and the aggregate values by the dashed line. The numbers at the end of each graph series are the numbers of patients as of the most recent quarter. 1,355 for the site and 13,547 across all sites. The 2 horizontal lines are the 25th and 75th percentiles. You can drill down to look at the clinic results within a hospital over time. This is done by selecting one site's clinics over time option in the request drop-down box. We will keep the disease area as diabetes and the blood pressure indicator and denominator the same as the example we just looked at for the site. This graph shows results for each clinic across quarters. It also shows results for the site as a whole and for the system. You can drill even further down and look at results at the clinician level. This is done by selecting Compare Providers within a clinic option in the Request drop-down box. Physician level results can be combined for 1 or more quarters. For this example, we will combine 3 quarters for the new clinic. The physician numbers are graphed along the x-axis. The numbers have been assigned randomly for de-identification purposes. 3 physicians treated patients in this clinic for these quarters. Physician number 05509 treated 428 patients in the new clinic from the 4th quarter of 2012 through the 2nd quarter of 2013. 76% of these patients with diabetes' most recent blood pressure reading was below 140/90. The upper and lower bounds represent the 95% confidence interval. The graph also shows results for the entire clinic, the entire site, and all sites aggregated. In addition to chronic disease measure sets, the drilling platform has several other types of measures. The documentation set includes measures pertaining to how frequently certain types of clinical information are being entered into the electronic medical record. For example, one measure shows the extent to which patient tobacco use status is being assessed and documented in the EMR. The LSU HCSD Medical Home Program calls for medical home clinics to verify in the EMR that patients visiting their clinics are attached to their clinics as medical home patients. This led to creation of a measure to assess how extensively this verification is being done. At Lolly Kemp, during the most recent quarter, about 80% of patients visiting medical home clinics has their medical home clinic relationship verified in the EMR. The medical home access section includes measures concerning wait times for appointments and appointment kept rates. Among the measures, for example, is the median wait time for a new patient appointment in the medical home clinics. Over the past 3 years, the wait time for new patient appointments at Lolly Kemp has risen considerably, although the most recent quarter suggests a possible reversal. The increased wait time for appointments may be a reflection of a growing medical home patient population putting pressure on appointment availability. The Lolly Kemp medical home patient population has increased by about 13% over the past 3 years. The wellness area includes measures on blood pressure control, lipid levels, weight management, and immunization. Most of these measures appear in some of the chronic disease areas as well, but the wellness section versions cover the entire adult medical home clinic population. One measure shows the fraction of patients with blood pressure above 140/90 for all patients who are not chronic disease patients. The declining levels imply improved blood pressure control. Closely related is the measure showing fraction of patients with blood pressure sustained above 140/90, meaning they have 2 consecutive clinic visit blood pressures above 140/90. This measure also shows improved blood pressure control. The fraction of medical home patients with a lipid profile done in the past 3 years has risen, especially at Lolly Kemp. Among the lipid control measure is the fraction of patients with LDL, HDL, and triglycerides, all within general population target ranges. This measure shows considerable improvement over time, largely due to a strong rise in use of statins. The utilization area includes measures covering inpatient admission and readmission rates, emergency department visit rates, clinic visit rates, charges, and composite quality scores. For example, one measure is the annual inpatient admission rate per person in the medical home patient population. This shows a declining admission rate across the system, although not at Lolly Kemp, where the rate has historically been below the system level. This measure, like all measures in the utilization section, is adjusted for patient demographic and insurance status differences across sites. Also, in the utilization section, the graph's system levels are actually levels for the rest of the system with the site removed. For example, this graph compares Lolly Kemp admission rates to the aggregated admission rates across all other sites except Lolly Kemp. Closely related to inpatient admission rates is the average number of inpatient days per person over the past year. A limitation of our inpatient measures is that they include only inpatient events occurring across the system sites. The Lolly Kemp admission rates incorporate admissions of Lolly Kemp medical home patients, regardless of where across the system those admissions occurred. However, admissions at non-system sites are not included. We hope in the not-too-distant future to be able to work with OPH to incorporate inpatient stay information from non-system sites as well. The average annual inpatient charges per person in the medical home population also is available. Graphs charge levels are adjusted to be comparable across time, that is, adjusted for inflation. Annual emergency department visits per person also is available. The Lolly Kemp emergency department visit rate is somewhat higher than the rest of the system. Not surprisingly, the Lolly Kemp annual emergency department charges per person are higher than the rest of the system. The medical home and chronic clinic disease visit rates have been gradually declining both at Lolly Kemp and system-wide. Again, this may reflect a growing medical home patient population. The declining clinic visit rates are reflected in declining outpatient charges. Across the system, total charges, including inpatient, outpatient, and emergency department charges, have declined. However, at Lolly Kemp, there is no apparent decline due to higher emergency department charges offsetting any other declines. All of the utilization measures are also available for the chronic disease groups. For example, we can view inpatient admission rates for only heart failure patients in the medical home patient population. Across the system, the heart failure patients' admission rates show a gradual decline. However, at Lolly Kemp, the rate has risen sharply in the past 2 years. Various forms of readmission and revisit rates are available as well. For example, the 30-day readmission rate following hospital discharge. This readmission rate has been trending downward across the system, although the pattern at Lolly Kemp is not so clear due to smaller sample sizes. Lower costs may not be good if accompanied by declining quality of care or worsening access. Likewise, higher costs are not necessarily bad if accompanied by improved care or better access. To help put changes in charges and costs in perspective, we are working on developing measures of aggregate quality and access. For example, we have recently created a composite risk score that incorporates information from many process, outcomes, and access measures. The utilization measures include the average value of this score across the medical home patient population and within chronic disease subgroups. The logic behind the score's construction is that poor access, poor outcomes, and deficient care processes increase patient risk levels. Therefore, lower levels of the risk score are preferred. For Lolly Kemp, the risk score appears to be moving downward, as desired, over time. The same measure can be obtained for a chronic disease group, such as diabetes patients. The diabetes risk score also is moving in the desired direction. However, the overall level is higher than for the general medical home patient population, since having diabetes implies a large number of care processes and outcomes that can lead to increased risk. We are also working on ways to combine the risk score and cost. One current measure is what we call the Efficiency Healthcare Value Measure. Essentially, the measure attempts to compare the cost level required by the site to achieve a risk score to the cost level required by other sites to achieve the same risk score. This graph shows that in the most recent quarter, Lolly Kemp required only 77% of the cost other sites need to achieve the same risk level. Finally, the number of patients in any denominator group can be obtained by selecting the number of patients measure. For example, we can graph the trend in number of diabetes patients in the medical home patient population. The graph clearly shows an increase in the number of diabetes patients in the medical home population across the system. The increase at Lolly Kemp is not so obvious, given the scale of the graph, but it can be examined by using the Table tab. The table shows that the number of diabetes patients in the medical home patient population at Lolly Kemp has increased from 2,025 at the end of 2009 to 2,527 in 2012, an increase of about 25%.